Hi, this is Brian Kim. I'm going to share with you case number 99 in the best way to do cataract surgery series. This is a patient with a moderately dense lens with some zonular laxity in a deep anterior chamber, and you'll see mechanical fracturing techniques and how I'm able to still disassemble this lens efficiently and easily, even though there's a deep chamber with zonular laxity in this moderately dense lens. I like to use a corneal marker, which will help me to center and size my rhexis. I make my paracentesis incision first on the right side and then the left side, making sure the incision is flat to the iris plane, which creates a nice corneal shelf, and it allows me to achieve a self-sealing incision. I'm injecting some intracameral lidocaine and then some dispersive viscoelastic to coat the corneal endothelium and fill the chamber. I use a cannula to hold the eye and control the eye, and this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then enter. I push some more viscoelastic at the end, and this is the puncture style rhexis. Put the forceps sideways, go in, puncture the center, pull down towards me, grab the right side of the tear, and where you grab the tear will dictate the diameter of the rhexis. Go around circumferentially. Burp some viscoelastic out, and this is the capsular fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point it down, get a nice wave, rotate it back up, decompress the bag, point the tip down on the right side now. I try a little hydrodelineation there as well. We start to spin the lens. The lens is not wanting to spin, again, because of this zonular laxity I was talking about earlier. Irrigate the surface of the eye, adjust the sleeve length, lift the incision with a chopper, go in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, placing the chopper under the rhexis edge contra-incisionally, pointing the phaco tip vertically sub-incisionally, bisecting the lens in half, placing the chopper around the right heminucleus, pointing it centrally, pulling it centrally towards the phaco tip, and that should divide the right heminucleus. The chops were not that clean, or again, because of the sticky nature of the lens and perhaps because of the loose zonules, I rotated it and then did the same maneuver, and then I did the cross chop on that right side heminucleus. Lift that first quadrant with some vacuum and then emulsifying the lens pieces. Placing the chopper under the second quadrant, pulling it against the phaco tip and then crushing it. Lifting the pieces up, crushing it, and emulsifying the lens pieces. I always lead with the chopper because I know that as long as I'm under the rhexis edge, I'm be able to hook the lens piece up because of the length of the chopper tip. So I hook that last quadrant up out of the bag and then emulsifying it. You want to grab the anterior aspect of the epinucleus. Be mindful that you don't grab the bag in the process. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the iony handpiece. A little bit of epinucleus stuck there. Start sub-incisionally removing the cortical material. It's a fairly clean bag. Switch to polish mode, polishing under the rhexis edge, removing any remaining cortical material. So again, this patient had a pretty deep anterior chamber, kind of resisted the rotation of the lens pieces. I pulse into subincisional space, looking for any remaining cortical material. Fill the bag with cohesive viscoelastic, polishing under the rexus edge on the left side first. And then on the right side. I'm going to widen the incision for the 3-piece lens. Again, in these cases where I feel like the zonule is a little bit on the weak side, and then with denser lenses, I do prefer a 3-piece lens. Turn the barrel to the left. Let the leading haptic come out planar into the bag. Rotate my wrist 90 degrees counterclockwise to let the optic come out flat, using the Maltzman to dial in the trailing haptic. So I go in, activate irrigation, go underneath the optic, removing the viscoelastic from within the bag. And then removing the viscoelastic from under the rexus edge some more in the polish mode. And then I'll remove the viscoelastic from the anterior chamber and I'll hydrate my incision. So again, this patient had quite a bit of zonular laxity. These eyes tend to have a little bit of reverse pupillary block as well. You can see how much the pupil is moving here. That's because of the chamber being unstable after I widened the incision. So again, this patient has a little bit of a flaccid pupil as well as a floppy elastic zonules. You could tell during the spinning of the lens it was a little bit more difficult. The lens was a little bit sticky and a little bit on the dense side, but using mechanical fracturing techniques, being able to hook pieces up out of the bag, crushing the lens pieces, instead of having to push down on the lens, grabbing the lens with high vacuum to impale. I feel like this is just a more efficient way to disassemble this type of lens. So I hope this was helpful to you, and I thank you for your attention.